Good evening. I am Ravi Gupta, Director of HLF and Editor of eHealth magazine. I welcome you all in the evening today. This is a focused roundtable on achieving operational efficiencies in healthcare management. Healthcare is very important. I think all of you know on this table. And this is a very focused panel on, like, just now we were having a discussion with the panelists over a coffee that people are talking about increase the budget spend of on health in the country, but improving or increasing budget is one part of the story, and how do you spend that budget and how do you make that spending efficient, that's the other part of the story. So this discussion is about this second part, that how do you make your spending more efficient, increase your ROI. So to start with, I will invite my colleague Divya, who is the product head of eHealth at our Lex, to give a small intro, and then we will proceed. Divya, please come on stage.
Thank you, sir. Good evening. It is my pleasure to welcome you all to this roundtable on achieving operational efficiencies in healthcare management. This is a part of an initiative called Healthcare Leaders Forum, started by eHealth magazine, which is an annual flagship event of ours where we invite leaders in the healthcare domain to interact with each other and germinate new ideas on what can be done to transform the healthcare scenario in India. The background of the event, as I said, is bringing together the community of healthcare professionals and creating sustainable leadership. It is a pulsating platform for top leaders of healthcare industry to connect with each other. The healthcare scenario in India, as Sir just mentioned about the healthcare budget that the government of India spends on healthcare, and how it needs to be increased, and how it we need to ensure that we are spending it in the right way. So India is currently, the public health system is does not have a very good ranking in the WHO member countries, overall health conditions. And if you see our doctors per patient ratio and hospital beds per 100 population ratio is all very low. If you see, a villager travels an average of 2 kilometers to reach the nearest health center, which is of course changing now, and with a lot of telemedicine centers coming up, and government of India are taking up a lot of initiatives. So this is changing now. The need for a platform like this, we felt that there is a need to have an extensive education knowledge sharing session where we can, as I said, germinate new ideas and deliberate on key topics in the healthcare domain. There is generally less health awareness in the country throughout, and the treatment costs are high. We are also talking about managed care now in India. So what is the need for managed care, where people say that if there can be a third-party administrator to control the cost and quality of healthcare in India. So all those things are now being talked about. What are the opportunities and challenges to achieve better health standards, provide affordable healthcare, and create new leaders in the healthcare domain, and rapid appearance of digital technologies. This is something that we are going to talk about today, how digital technologies can help in achieving all these goals. And going ahead, I just want to give a brief introduction of what eHealth is. eHealth magazine was launched in 2006, and initially as a healthcare ICT magazine, but when going ahead, we realized that there are a lot of things that are associated with healthcare IT. So just being a healthcare IT magazine does not serve the purpose. We need to focus on the entire enterprise of healthcare domain and see how IT can help change the scenario. So we were launched in 2006. Our current focus is on healthcare ICTs, medical technologies, public healthcare, health insurance, medical education, and many more such topics that are very important. eHealth is a premier print and online monthly publication We reach our readers through 3 unique media platforms, which are print, weekly newsletters, and a web portal. These are some of our past issues. Our partner publications include eGov, which is Asia's first monthly magazine on e-governance, and Digital Learning, which is Asia's first monthly magazine on ICT in education. We also organize a lot of events, and like this one is one of them, Healthcare Leaders Forum. An event called E-India Health Summit is being organized by us in November, in 15 to 16 November in Hyderabad. So I would like to take this opportunity to welcome, to invite you all to that event also, and of course we'll be sharing more information with all of you. With this, I would like to again take this opportunity to welcome all our eminent panelists. If I may introduce all of them to you. Dr. B.S. Bedi, Advisor Health Informatics from CDAC. Dr. Rajiv Kumar Jain, Additional Chief Health Director, Hospital Administration, Indian Railways. Shri Anil Swarup, Director General, Labour Welfare, Ministry of Labour and Employment, Government of India. Dr. Pradeep Saxena, Director, CBHI, Directorate General of Health Services, Ministry of Health and Family Welfare. Dr. Tarun Seem, he has been a health specialist and he's been associated with Public Health Foundation of India, and currently he's with the Income Tax Department. Dr. S.K. Karasu, I'm sorry sir, it's a very difficult name to pronounce, and he's the Deputy Director of HMIS for Tamil Nadu Health Systems Project. And we also have Shri Vishwajit B. Renge, Scientist at NIC, and Dr. Sunil Kumar, Senior Technical Director, NIC. We are thankful to SAP for supporting this event. Before we start the panel discussion, may I invite Mr. Subroto Das, who is a representative of SAP. He has 20 years of experience in public sector. Previous to SAP, he was the General Manager with Oracle, and his focus was in healthcare, higher education, tax and revenue, urban and public security. He works closely with the industry and market unit to drive leadership and innovation for SAP. Mr. Subroto Das, please.
Thanks. Just a small clarification. It's not SAP. We call it SAP. Good evening, ladies and gentlemen. It's really a pleasure to have you here. I know you put in hard hours at the office and come to listen to us. And we are also honored to share the days with you, understand some of the insights that you can give us. SAP is a technology company. It's the #1 business software company in the world today. Okay, and I only look after a small part of what SAP, the industry that SAP typically addresses. We've got 24 industry verticals for which we have solutions. I look after healthcare, higher education, and what is typically known as the public services, which is your Panchayati Raj, urban management, tax and revenue, so on and so forth. And of course, there are other colleagues of mine who look into the other industries. And knowing your background, and once they read out the profiles, I almost feel like a patient today because I'm not around them. Okay. But I'll try and give you a glimpse into the solutions that we have built over a period of time, especially for the healthcare provider segment. Okay. Now, in other developed economies, there is a clear distinction between a healthcare giver and a healthcare provider and a healthcare receiver communities. And each community has a specific business requirement or a solution requirement, and there are solutions built for them. So we'll concentrate on the healthcare providing community today. So these are some of the customers that we have across the world. As you can see, over 2,300 customers in more than 60 countries. Some of the names you are already very familiar with. People like Johns Hopkins, Mayo Clinic. These are some of the gold standard organizations in providing healthcare, both in provisioning of healthcare as well as in healthcare education. SAP has been partnering them for quite some time now. whether it is in the area of hospital management systems, whether it's in the area of back-end systems like finance, medical supply chain, so on and so forth, but also in the area of providing solutions like electronic medical records, knowledge management in the area of healthcare education. So, based on this client base and the solutions that this particular segment required, we started building our industry solution for the healthcare segment. I had a look at the structure of the healthcare provisioning system in India, and we see that there's a huge responsibility of the state in India ensuring that the right healthcare services reach the citizens. There is a national body which provides policy, planning, grants, so on and so forth. And then from the district level is mostly execution of the plans and programs set out in the country. We have secondary, subdivision taluka level, we have the primary healthcare level, there are sub-center levels also. I think the primary healthcare level is being replaced more with the sub-center level now. Given this kind of a structure, there are requirements at each and every step of this structure. So if you look at the service delivery map, this is what it typically looks like in India. I mean, you are all clear about this, you live it day in and day out, but just to be, on the right side of the solution, this is the healthcare structure that we are looking at when we are building a solution footprint for the country. Just a point here, we've got about 5,000 people working for SAP in India, out of which about 3,500 people are in the SAP labs. I have two colleagues of mine from the SAP labs here, and they work on some of the localized solutions that India needs, solutions that are unique to our country. And we keep on adding these assets onto the solution footprint. So our solution footprint starts with the basic needs of the healthcare segment, but then over a period of time it evolves into more or less addressing some of the more critical issues facing the Indian healthcare industry, the Indian healthcare system. And we all know the problems. I will not dwell on this slide. I think as a country in the last 65 years we've achieved quite a lot. But then if there are problems, and so there will be an ICT intervention. So just to tell you that these problems exist, and all of them there are policy level inadequacies that we have, dismal pace of reforms, talent attraction, retention. IT is not going to make healthcare provisioning better, but it's definitely going to address some of the key issues that we have in the country. Managing the plans and programs, managing the funds that are allocated in plans and programs, managing the projects under the plans and programs, automation of the hospitals, 360-degree view of your patients, understanding who your patients are, what kind of preventive care is required for them, what kind of intervention care is required for them. So I think ICT will help you achieve up to a certain extent, but then there are structural reforms which are required, which I will keep outside my purview of my presentation, but I can't influence that. You people are here, you are the think tank of the country, you should, you are driving this policy level enhancements for our country. This is the National Health Policy and the Charter. One important thing that I found out while I was going through some of the healthcare specific issues, the number of doctors, per a particular segment of the population, depending upon the terrain and the availability of an urban infrastructure nearby, it ranges anywhere between 20,000 to 30,000 people. I think in our country where our GDP growth is increasing, our GDP is increasing, our industrial output is increasing, everywhere there is development. I think the value of life in our country is somehow not come up to the mark, wherein we can really say that we have achieved those development parameters of some of the developed economies of the world. And this is one area where I think India must be concentrating on. And it's not only the doctors. Some of the diseases that are there prevalent in the rural segment can be addressed by paramedics. And I know there's a huge movement around midwives and Anganwadi workers who address some of the basic issues of healthcare, hygiene and sanitation at the rural level. But I think we need to put our act together. There have been, interventions of telemedicine. I have personally worked with some of the telemedicine projects that have gone on. I think the issue is that we've done it in bits and pieces. Now we need to put the story together. We should be proud of what we have done, but I think now, at this point in time, we need to deliver a solution to the government. Tell that, okay, your structural reforms are in place. Parallelly, you should have a solid architectural model which is in scale with the kind of issues that we have in the country today. So from a functional overview, if I see what these different hierarchies in the health provisioning system in India do, we will see that there are, this is the central ministry and the state departments, the medical directorates, and the tertiary, secondary, and the primary centers. What I have done is I have divided the functional requirements of each one of these entities and then seen from an ICT intervention perspective what they typically require. Because at the central ministry and state departments there is no medical management or patient management requirement. It's mostly policy, programs, plans, financial accounting, grants management, so on and so forth. Budgeting and planning, which is a very important aspect of our healthcare delivery system. Most of the time our budgeting and planning is bottoms up and then intervention at various levels, because there will be a social aspect, there will be a political aspect, and a lot of these aspects come together in the formulation of the budget. But since we don't have access to all levels of the governance today, our budgeting and planning is something that needs to be tightened. From a plan monitoring perspective, because of again accessibility, availability of the communication network, we don't get the information in time. So monitoring the plan becomes difficult. Second is, even if I get the information, I mean, gentlemen like the one sitting here, you all don't have time to go through porous reports, turn over 60 pages and see what's actually happening in your territory. You would want to have a simple dashboard, and you would want to click on a particular geographical area, be it a district or a taluk, and see the basic health parameters there. Whether it is in terms of the vector-borne diseases that are there, whether it is in terms of any pandemic or epidemic outbreak that may happen, the kind of demographic and psychographic profile of the patients living in that area, and take decisions based on that. So, if you look at the SAP solution story, so at the ministry, department and the directorate level, it's basically our solutions for the public sector. We are looking at issues like file lifecycle management, which is like your digitized file movement within the ministry. We're looking at budgeting and better budgeting and planning. We are looking at, human capital management, HR, payroll, so on and so forth, which are basically the back office operations for a particular department. But the moment you go to the primary, secondary, tertiary, and the healthcare facilities, that is where I think the cookie is crumbling. Because this is where I am actually interfacing with the government. When a villager, and me as a villager, go across to a primary healthcare center, the experience that I get or the treatment that I get forms my opinion of the healthcare delivery process. We may have big think tanks there out there at the top, but if the delivery does not percolate down to the rural level, I think our healthcare provisioning, the success of the healthcare provisioning only would come when me as a villager or a citizen of India will feel that the public healthcare system is delivering for me. So this is the public healthcare system in a box. In a box meaning the end-to-end requirements of the healthcare system, right from policy making, right up to patient management. All the solution modules are there, available within SAP in a modular manner. It does not mean that you need to take all of them, because you may not require clinical information at this point in time. Because why do you require clinical information? Because you are not storing the clinical information somewhere. I would want to store clinical information because next time you come to the hospital, I would like to know your history. If I am not capturing your history, what's the point in capturing the clinical part of it? Okay, so this is the solution in a footprint. I don't want to spend too much time on this, because you can spend about 2 hours on this particular slide itself. Another issue that I would like to highlight is that while these are modules, they have a seamless integration between them. the nursing would speak to the ward would speak to the pharmacy would speak to finance. So there is integration between all the modules. Even if you take a modular approach to development or modular approach to the implementation, say you start with something now, you move on to something later. But this integration points is, the application integration issues remain constant over or are taken care of across the entire solution footprint for SAP. These are some of the assets that we keep building over a period of time to enhance the efficacy of some of the solution footprint that we have for any industry. And for healthcare segment, we build this electronic medical records. Now, EMR has been tried out in several countries today. I mean, if you try to do EMR for India, it will be as big a project like the UIDAI and probably more complex because you are dealing with DICOM images, you are dealing with health standards, you are dealing with regulatory bodies, so on and so forth. But even if you had to do that, what's our biggest stumbling block? Accessibility, availability of a network. How do I capture the information at a village level and then consolidate at a district level or at the state level? Now, with the help of mobility, where SAP again is a market leader, number one in the world today, we build solutions where the database is on the iPad, or it could be any other smart device, and the person can go and take the EMR information onto this mobile device. The data gets stored on that embedded database, and when he goes back to the district where there is a network available or even a mobile network available, he can upload the data onto the central database. And there are several fields that he needs to fill while he is doing the process. Some of them are clinical, some of them are required from a demographic perspective. All of them have been mapped, and I will show you a few movies which will capture some of these assets that we have built over a period of time. Another issue that I touched upon during the second slide of my presentation was the need for actionable insight, especially in a healthcare segment. Every business, and if you pardon me for calling this a business because this is what we are running, for us, any process is a business because it either touches a human being or it touches a financial instrument. So for us, every business requires actionable insight at any point in time. If there is a bottleneck in your budget formulation process, your BI dashboard should be able to tell you where it is. You should be able to drill down and understand where the problem lies. You should understand whether there is an over-allocation in a particular segment, whether there is an under-allocation in a particular segment, whether gender parities have been maintained in some of the budgeting and planning that we are doing. So some of these, BI template, this is more from a hospital management perspective, which we have shown here. But there could be dashboards built for the plan and program managers as well. This is a collaborative e-care management solution that we had built for providing geriatric care to patients under NHS in UK. You will realize that patients with chronic conditions, like whether it is diabetes or non-stereo hepatitis, will require constant boarding, especially at that age, to ensure that they remain on a diet and they remain on a medication plan. Most of us, which includes people like my father, will not stick to those. And this, and because they would be under public healthcare system, they would feel it's their right to do whatever they like and then go and tell the hospital to provide the services that are required to intervene and solve the issue, or at least alleviate the problem that he has. But then there's a huge pressure that comes on the public healthcare delivery system because of chronic diseases. Understanding those chronic diseases and providing a delivery mechanism, a support mechanism, something like an Alcoholics Anonymous. Okay, there are support groups, there are tags which are put around these people so that the vital signals of the physiology go back to devices, and for each and every patient a profile is created, and whenever there is an aberration, there are people sitting with the help desk and then the intervention happens. So this takes away some of the stress from the OPD and some of the healthcare provisioning centers that they have. So the point that I am trying to make is whether it is at the policy level or whether it is at the healthcare delivery level, SAP has solutions, and with SAP you the end-to-end integration of all these processes happen. Unwired EMR is something that I showed you. Another innovation that we have had is in the area of in-memory, wherein huge volumes of data, when you fire a query on them, because of the data size and because of the multidimensional tables at play, response and throughput performance often goes down. And especially when you are dealing with clinical data, which is very voluminous in nature. And look at our population with 1.2 billion records, multi-ethnicity, different patient types, different body types. You get a plethora of information, but understanding what do I do with that data becomes difficult. With HANA, we developed a product called Oncolizer. So it captures a lot of information about a particular patient, whether it is his genome data, whether it is his electronic medical records for the past 15 years, and tries to understand that if a person has an oncological condition, what are the chances of his survival going forward and what kind of intervention should be made ready for him. So see, this is a dashboard that we had prepared for Southern Australia. A lot of families of the patients go across to emergency and trauma centers and they admit their patients. And then they sit outside without knowing what's happening to their patient. Sometimes they get irate. You all are aware as to what happens at our government hospitals. Just because there is no system, the poor doctors who are attending on that patient, they are under tremendous amount of pressure from the families of the patient sitting outside, from other such elements. But having a system like this where patient bed number this, he's been moved from ICCU to general ward, this gives a sense of time and place to the families of the patient sitting outside and understanding what is the availability of beds at that point in time. Transparency is very important for our country. I live in Delhi, but I used to live in Calcutta before. And taking an accident victim to a government hospital was a trauma for the person who took that particular patient. Because even if the bed was not there, because of our experience, we would say the bed is there, he's probably, wanting something in kind of cash to make that bed available. But this sort of systems increases the transparency. It does not solve the problem, but at least improves the transparency, and the government decision makers also know that I am having this problem every day where 5 patients are there in my trauma center and my board shows that my beds are full. So that basically means that I need to increase the number of beds or I need to increase the number of personnel attending to the trauma care center. So these are some of the stuff that we do. I could go on and on. In the paucity of time that we have, what I'll do is I will run 2 small movies for you, just to where are the movies? I got it, thanks. Would you have the sound, please?
The clinical working place of the future is mobile. SAP EMR makes it possible to access patient information reliably and in real time. It's important that the data is accessible in every part of the hospital. Charité is the biggest university hospital in Europe, but size is not the most important thing. It is also one of the leading university hospitals in Europe. Today, doctors are to a large extent also organizers and secretaries for patients, and that's something that distracts them considerably from the traditional profession of being a doctor. If you look at medical workplaces today, they are overcrowded areas where doctors and nurses have to type up all the data. Time spent on manually compiling data needs to be reduced in the future. At the same time, the data has to be instantly accessible. In order to gather experience, we are using SAP EMR in a pilot project so that patients' health records are accessible on the go.
Ziel von einer mobilen
The aim of using mobile technology on ward rounds is that we can always find the most recent results for every patient and have access to these results, not just in one place, as is the case with paper files that can only be in one place, but at the same time in different places wherever they're needed. This means when an examination is done, it can easily be documented, and so everyone else on the ward can be briefed on its results. Searching for documents is no longer necessary. There is no need to create a to-do list manually and then later transcribe your notes in your office. They're transcribed when you make the decision.
Eine besondere Stärke.
So you get the idea. I know I'm running short of time, so there's just one more which I wanted to show you here is on this oncolyzer thing. I really like it because there are use cases for it in India.
Invasive cancer is the second leading cause of death in the world. In 2008, approximately 7.6 million people died of cancer worldwide. Doctors and researchers are aggressively searching to find a cure and better treatments. The answer to this deadly disease is hidden in the human DNA. More and more physicians are not only searching for changes in human tissue, but are increasingly interested in alterations of the human genome, because from that we can already identify certain changes and better predict if a therapy will be successful or not. Tumor scientists at the Berlin Charité are on the case, analyzing cell structures of tumor tissue to find out the best therapy for each patient. This process generates huge amounts of data. During patient-specific genome analysis, we produce terabytes of data. Of course, this data comes on top of the clinical data from radiology to X-rays, clinical findings, or administrative data, which are generated at patient admission. That's why the Charité team uses SAP in-memory technology. The innovative research initiative called HANA Oncolyzer brings together the Institute of Pathology at the Berlin Charité, the Hasso-Plattner Institute, and the SAP Innovation Center Potsdam. Using SAP HANA, we can analyze huge amounts of patient data. In case of cancer patients, these data have been collected for years, and using HANA technology, we can analyze it in seconds.
Again, you will have access to these movies, and when we communicate with you, we will hand them over to you also. They're also available on the public domain. Now, solutions does not necessarily mean that it will work in India. We've tried a lot of ICT interventions, and some of them have been failures. A lot depends on the innovative way of how you bring these solutions to the citizens of the country. I have Puneet here with me. Puneet is from SAP Labs. Now, vaccination, understanding the vaccination routines, understanding the vaccination calendar, administering the vaccines, what do you do when the vaccines are not given in time? If a child misses a vaccine, what do you do? Understanding whether the child has gone through the entire vaccination schedule. These are some of the challenges that we have at that level, because some of the departments in India are entrusted with that charter and providing that vaccination, basic vaccination to the children. And in spite of the huge amount of money that we spend and the huge programs that we run, often we are unable to gain the maximum amount of productivity out of these programs because of several reasons. While the healthcare condition needs to improve, there has been sufficient improvements in the way we have been addressing the area of illiteracy. And almost 95% of the children are going to schools today. So schools for us become an important medium to reach out to this case. I don't want to take the thunder away from me. So I'll just do a quick swap of machines here, and then Puneet can show this small demo. Try and be as concise as possible because we are in the time.
which basically looks into the Indian scenario, and we try to develop solutions which make sense, which are India specific and probably make sense for the India specific conditions. So okay, so health.edu.in is the solution that we are working on currently. So what it does is, what we realized is, we looked at the state of health service delivery in the country, and what we found that India has made some good progress in terms of, India has been declared as a polio-free country sometime in February this year. But at the same time, there are a lot of issues. If you look at the global scenario and where do we stand in terms of the leading countries in the world, probably we are lagging quite a bit. At the same time, if we look at the education sector, probably we have made some tremendous growth there. So recent census reports showed that 75% of Indians are already literate. About 95% of the kids in the age group of 6 and 14 are already enrolled into schools. They are going to state-run schools. So what is the challenge in the delivery of health services is what we were trying to tackle. And what we found after our discussions with various health service agencies and the people on the ground who are, for whom the services are meant, what we realized was budget, healthcare infrastructures are definitely some issues which needs to be addressed. But at the same time, what is interesting is accessibility is one of the major challenges. With about 15,000 hospitals in the country, probably reaching out to 1.2 billion citizens of the country is a huge, humongous task. So okay, reachability, accessibility will come with budget. Once we have money, probably we can set up more and more, and education can train a lot of doctors. But at the same time, the issue which was most surprising for all of us was awareness about the health services, the availability of health services, the benefits that can be derived by availing these services is not there. People are not aware of the basic things which they should be taking care of. So we started thinking about how we can resolve this problem, probably what kind of solution can we develop. And what we realized that why don't we use or leverage the growth and the progress that we have made in education sector to fulfill this gap which is there in the healthcare service delivery. And that's the idea that we have been working on. So we have already done this pilot with a couple of NGO run schools. We have done it, the pilot in the tsunami affected area of Tamil Nadu, the earthquake affected areas in Gujarat, urban areas in Delhi, and semi-urban areas in Bangalore. And it is, we still have to analyze the result, but so far it's been looking promising. Okay, so what health.edu.in is all about. So I'll try to just first of all give you a short demo as to how this application works. So this application, the idea behind this application is that this will get installed in the school. The school administrator will feed in certain data of the students. So what it means is 95% of the children. And so suppose that I am the school administrator. I log into the system. I get to see a snapshot view of what the health status of the school is. What it means is, okay, so many children are suffering or having some ENT issues. So many of them have a weak eyesight. So many of them have some sort of allergy related to some particular chemical or whatever, some food. So many of them have not yet been vaccinated for particular vaccine. So this is the view that I get to see initially. Now to get to this view, the data that I need to feed in is very simple. So for example, take an example that Ravi Prasad is a new student who comes to school for the enrollment. Yeah, I think so. So what happens here is Ravi Prasad is a new student who has come for enrollment. I am the administrator, so all I have to feed in is some basic data, And the important data that I'm looking at here is first the phone number of the parent of the child, and second is the age of the child. That's about it. These are the two major critical fields that I want. As soon as I do that, a schedule is automatically created by the system based on the date of birth of the child, which all vaccination and what kind of health checkups are required for this age group. So that information has been fed into the system, and system automatically generates that. All I have to do is just select the things that have already been provided to this child and probably highlight the things which are not yet been provided. Now as soon as I do that, I get to a screen where I get a snapshot view of all the students in my school. How many of them are due certain vaccination, how many of them are overdue certain vaccinations or follow-ups, and what needs to be done. So what we also realized is when we were working on this is there are medical camps organized in each such schools where they invite a general physician who comes and carries out a preliminary checkup of every student in the school. What they look at is, okay, your eyesight is okay, yeah, seems good, ENT checkup, allergies and these kind of things. And these schools then try to follow it up with the parents. So we have provided a provision in the system where such follow-ups can be maintained. For example, Ravi Prasad has a weak eyesight, because of which he normally has a lot of headache, because of which his attendance is going down and his academic performance is also getting affected. So for these kind of things, schools can automatically feed it into the system, and the system automatically generates a call in the background in the local language of the parent. So we are not using SMS technology, because SMS, what we realized, people don't know how to read SMSs. Normally their inboxes are all full and nobody knows what to do with that. So we are using automatic call mechanism, we are using IVR in the background. So this is what the system does. It's very simple use case, we are not trying to achieve too much out of it. The idea is to provide data to the health agencies, relevant data, proper data, structured data, cluster specific, geographic specific data, which can be used to plan and provide the services in an efficient manner. So I'll just show you a video which is from a school in Bangalore where we deployed the system.
Every Indian will have in a few years, almost every Indian will have an Aadhaar ID, a 12-digit number that uniquely identifies the person. An Aadhaar check enables Indians to prove their identities from anywhere in the country. Using Aadhaar numbers, health agencies can keep better records of vaccinations. They can determine when vaccinations are due and which areas are worst affected during crises such as the H1N1 epidemic. TrackerVac is an application that tracks the vaccination details of every school-going child. When the next vaccination is due, TrackerVac informs the child's parent by calling them on their phones in their regional language.
Immunization is a very important initiative, and hence it must be institutionalized. Technology can definitely play an important role, and this is why we are excited about the partnership with SAP, as it will ensure every child in a Hope Foundation school is vaccinated.
With this solution, we will be able to develop a close association with the parents, and also it is gratifying to note that all our children will be vaccinated and lead a healthy life.
Now I don't have to worry about remembering the dates. TrackerVac calls me.
TrackerVac, built on SAP HANA, allows us to process a staggering amount of data in an unprecedented speed. Together with Aadhaar, the unique identifier for every Indian, TrackerVac will actually open complete new avenues for services in the healthcare sector in India.
Thank you.
Thanks, Vito. I think in the last 30 minutes that we actually trying to tell you that we have a solution, and there are a huge amount of innovations that are happening around the healthcare segment at the SAP labs as well as we've been able to kind of tell you the range of solutions that we possess which can help you. But at this point in time, I'm dying to actually hear from you as to what you feel are some of the endemic issues in healthcare in India, and how can actually ICT intervene in alleviating some of the problems. So thank you, sir. Thanks for giving us the time. Thanks, Ravi. Yeah.
So we had an I think amazing demo of the various solutions and possibilities in healthcare. And it's an honor to have an eminent panel here, and I would invite Sri Anil Swaruji, who is a Joint Secretary for Ministry of Labour, and leading a very, very important program which is impacting the healthcare ecosystem of India in a big way. The RSBY program, Rashtriya Swasthya Bima Yojana. So I will invite him to talk about it and how he sees that the around 10,000 hospitals which are in this network now are being managed, coordinated, and how is he able to run this massive program with so much high impact. So may I, sir, invite you on the stage.
Good evening, everybody. At the outset, let me confess that I'm neither a technologist, nor a health expert, nor an insurance expert. I'm a thoroughbred bureaucrat. So, pardon some of my ignorance as I go along to express my views on what can happen, what has happened. But my context is slightly different. It's not what you saw in the movie. My context is the poor man who will probably not be studying in a school that was shown here. My context is a hospital which will not be using the gadgets that were shown here, oncology and other things. Because we have come to discover in the past 4 years that the poor man does not die of kidney transplant or heart failure. He dies much before that. He dies of typhoid, malaria, diarrhea. So probably the sophistications that came through in the presentations are not there. And the hospitals that we have, about 11,000 hospitals that are empaneled, are not Maxes or Polos. And my advice to SAP, because I think I have some knowledge about what they're doing and using some of the technologies that they're using, is that while you do business in India, because many people are doing business in India, Maxes, Apollos are doing business in India. They've graduated from business to making it totally commercial. We have to reach out to this poor man. And we have to see how technology can help reach out to this people. Technology can. I have absolutely no doubt. Being user of technology ourselves, with 32 million smart cards touching 108 million people in the country, all through ICT application, evolving the one and the only one cashless health insurance scheme using ICT applications. And these are all poor people. So my first request to SAP, I think you'll have to move beyond Bangalore city and don't go to the exceptional areas of tsunami and earthquakes, because they are exceptional areas. Why I say that? Because if you do a pilot there, your pilot will not fly. In any case, India, literally and figuratively, Indian pilots don't fly on occasion. More often than not, they're on strike. So you have to be careful about what you choose as an experimental project, because ultimately the value of it will lie in your ability to scale that. If you look at the pilots that have been done in India, not even 1% of them have actually been scaled. I mean, that's not a number even, because we are all very fond of pilots. We somehow make them work, put in everything. And I saw people talking as they were in the film. But I can guarantee it will not scale. Because you have to pick up a situation which can be scaled. So you have to take a normal situation. Don't take an abnormal situation. Fortunately, we will not have tsunamis all over the country. So you have to take a situation where it is not. There are huge areas they can do it. Because when you do that, you have to look at 4 basic parameters for you to scale. Whatever you are trying to do, and fundamentally I would totally agree with you that today, ICT application can solve a number of problems. In fact, I used to wonder about our obsession with laws, because when British left this country, they took justice with them and left laws and outlaws behind. So we are so obsessed with laws that we think if we have a Lokpal, Janpal, this pal, that pal, all problems will solve. I wish it could do that, because in labor, where I am in labor ministry, a pun, where we have 44 labor laws, yet we have humongous problems, labor problems. And we have come to understand that laws have a value, but laws do not solve your problems. It's the operations. The key is operations. And here I'll come to you mentioning about Aadhaar. And I hope it's not recorded, because as an official I can't make those statements here. Can you switch off the camera? Then I'll tell you something very interesting, because your entire model is based on something which is not happening. Typewriters in government. And it was, a status symbol to have a computer in your room, whether you knew how to use it. Let us not make ICT as a status symbol. In government there is a problem, because quite a few of us don't really know how to use ICT application. We try to become technologists rather than understanding processes. We are good at, we should understand processes. Let technology be done by technologists. And if we can communicate with the technologists, things will happen. So what the technologist has to do, and what the processor, an administrator like me has to do, is to understand the processes and be able to communicate with the technologist. Now this is nothing to do with technology per se. So the problem with ICT is not ICT itself. There are solutions. Like let me use the health parlance. There is a diagnosis, there is a prescription, there is an application. I don't think diagnosis is an issue today in India. I don't even know whether the prescription is an issue. The real problem is application. And that's the point I told Nanda when he met me. He was told that there is a man called who is doing some smart card work going meeting. When he came here, I told him, no one will ever question you on technology. You will tear your hair out when you come to operations. And he's doing that precisely. He doesn't know what has hit him. The reason is very simple. The problem in this country is operations. And when you look at a solution, you look at that end. Start from that end. So I'll just give an example and then close here, because I like to hear many of you. As I said, I'm not an expert. I'm a practitioner, basic, pure and simple practitioner. When we started RSBY, why did we look at technology? And we looked at why first before going in for technology. Right now today, because after your film, everyone would want to jump onto this technology. They'll give you business. They won't know how to use it, but it looks very good. There's somebody talking so well. So they'd like to have that technology without understanding how they use technology. That's the problem with the use of technology in India. What we did with RSBY was, we looked at the beneficiary, because he's the focus. The beneficiary was poor, he was migrant, he migrated from one place to the other, and he was illiterate. Now, it is in this context that we look at the technology. Why? Because since he was poor, he could not pay upfront, so it had to be a cashless scheme. Now, could technology help me to deliver a cashless scheme? Second, since he migrated from one place to the other, could I give him an entitlement which he could use anywhere in the country? There is no scheme in the country where your entitlement in one state can be used elsewhere. So it was a huge challenge. And third, these were by and large illiterate. All these were by and large illiterate. So I had to have a paperless health insurance scheme. It didn't exist in the world. It didn't even exist today, except RSBY. What do? Once I understand my requirement, then I go to technology. And I find something called a smart card. A smart card provides solution to all these three problems. It enables me to put the entitlement in the chip, so he doesn't have to pay anything. Identification is there, no signature, no paper, everything goes through ICT. We don't use paper in the scheme. And then that card can be used anywhere in the country. So technology came after we understood the process, after we understood the requirement. Sometimes, as I keep saying this word, sometimes we get so carried away with technology that we want to have technology anyway, anyhow, because that's the fashion. So in government, I keep pleading with my colleagues that don't jump into technology unless you understand, because that's what technologists will not tell you. You must understand what the problem is. So the problem is around technology, not technology. Technology is a tool and it can be used very, very effectively. What we are now doing is, and that will be a game changer in this country. Mark my words, it will change the game in this country. We are going to use this smart card for pediatrics. And a paper which I wrote a year ago, published in the Economic Times, using IMM data, established that the country saves 20,000 crores per annum. 20,000 crores of rupees per annum if RSBY smart card is used for PDS. This is going to happen. It starts in Chhattisgarh on the 1st of October this year. Thank you very much.
So a massive program like RSBY runs on smart cards, which is all ICT, and I think we have a great success story here. May I now invite Dr. Pradeep Saxena, who is the head of the Central Bureau of Health Intelligence and Director General of Health Services, Ministry of Health and Family Welfare. Kindly come on the stage and give your views on the ICT in health, sir. Please, welcome.
Good evening to all of you. At the outset, let me thank the eHealth magazine and its entire team of dynamic persons to invite me here and speak before you. I fully agree with my previous speakers, especially SAP person from SAP. We have already got the overview of what technology can do in the healthcare sector. Let me assure you at least one example that even in government sector in India, one example he gave that in the emergency care dashboard that ICT can help, and I have seen if you go to AIIMS Trauma Center in Delhi, they are actually using it. So it is a question of willingness. If the hospital administration wants, even if either a new hospital coming up or an existing hospital, if they want to use this ICT technology, that dashboard I have seen, minute to minute patient is moving from emergency room to say dressing room to X-ray room. Minute to minute the status is changed, and you can't every time ask nurse or doctor what is happening. The dashboard gives information. Only thing again in India, my previous speaker mentioned that most of India, suppose it is illiterate person goes, of course, so it requires at least little bit literacy to go through that dashboard. But the technology is there. How to use that is up to us. But why I am giving example, wherever there is a willpower on the part of say hospital or health authorities to use technology, technology is there. Technology is there. Solutions are there. We all know. Most of us sitting in solved no. Question is availability and the willingness, administrative as well as political willingness. And similarly, coming to the public health situation in India, out of 35 states and union territories, we all know there are in India is a one country. In one country, India, there are many states whose public health system is good, and one we all know is in shambles today. Why it is so? If we analyze as a public health expert, the reason is very simple. States which for the years the administrative and political will to do or to improve the public health system in the state, those states are doing well already before the NHM came. Long before NHM came, they are doing well. Now NHM has helped them. But states where these political administrative problems are there, people don't want to work, people don't want to do things, there it will remain. So use of technology as we all know is a tool, but using tool and making it easy and to our entire population, most of it are illiterate population. So that challenge lies with the health administrator as well as the political and administrative leaders. So with these small remarks, thank you.
In the SAP presentation, it was like talking about health intelligence. So I hope that Central Bureau of Health Intelligence is like looking at ICT to have intelligence using ICT. I will invite our next panelist, Dr. Rajiv Kumar Jain, Director of Hospital Administration in the Indian Railways. Now, Indian Railways is one of the biggest, one of the big, I will say, networks of hospitals they have. So great to have like their views on this subject. Welcome, sir.
Thank you, Shaili, Divya, and Ravi. for two reasons. One, to think of a round table on a rectangular table. Yeah, we will live in an era of paradoxes, and we have to create and to visualize round tables in a rectangular framework. And I hope what Mr. Anil Shru told in the beginning proves my experience. In this era of trying to find out operational efficiency in healthcare sector, sometimes you lose sight that healthcare is a broader framework in the social development framework. If we have to achieve health status in a developing society in India, we tend to presume that the intervention will lie in the health sector, which is the biggest myth in the medical education in our country. Most important intervention which will transform the healthcare scenario in the country, surprisingly, and it's available in all international documents, leave aside the national documents, is the nutritional deficiency, the malnutrition that is prevalent, whether in utero or outside after birth. Yet, the interventions and all the arguments in the public fora that I hear are focused on intervention in the health sector. So if we were going to talk on operational efficiency in the healthcare sector, we need to move away from healthcare-centric prescriptions or descriptions or analysis to non-health sector interventions, descriptions, analysis, and understanding and learning. That would be one. That myth, and this over the last 32 years of my graduation from Maulana Medical College in New Delhi, I think after 32 years of my graduation, I feel that is the biggest learning I've made in 32 years. So I would say 5 major paradoxes we need to tackle, and this is an indication to SAP that the myths in the medical textbooks and myths and realities are to be balanced. India is a land of paradoxes. It shall remain a land of paradoxes. The 5 major framework, or the 5 corners of this framework which I feel is important at this round table, if it becomes a round table in reality, Ravi. Facilitators versus providers, which is the right mode of provision of healthcare in our country. We need to, as a government or as a provider, whether in the public sector or the private sector, we need to be facilitators or we need to be providers. I have a feeling that we have always thought ourselves to be providers rather than being facilitators. As if everything is going to be happening within the state government health department, or as if everything is going to happen within the central government health department. As if nothing happens outside, which is a thing to be thought about. I'm not answering any of these paradigms. Second framework we need to address is indirect financing versus direct financing. When you talk of operational efficiency, it cannot happen unless we clear this paradox of whether indirect financing will be more efficient or direct financing will be more efficient. I have a feeling all through these last 60 years of our structured planning process, we are focused on direct financing, while actually operational efficiency may lie through indirect financing routes. RSPY is a wonderful example of the success of this model. Third framework which I would like you to consider is regulating versus executing. Out of these two, which appeals to you more? Whether you need to be an outstanding regulator to be effective, to achieve operational efficiency, or you need to focus on more efficient execution of the business of healthcare. I have a feeling if we really have to succeed and achieve operational efficiency, we need to focus on how we need to create a structure which is outstanding in terms of regulatory framework rather than outstanding executioner. Because operational efficiency will happen if we have a single-minded focus on creating a good regulatory framework and structure on the ground and in terms of national and regional and local planning process. Fourth, I have already mentioned health-centric versus non-health-centric planning process. I have a feeling in Indian context where the major causes of illness, as Mr. Anil Swarup mentioned, are not directly related to health per se as is understood in the Western text, which is disease-centric. In our part of the world, it is more of health-centric, which leads to more of health status-centric, not disease-centric, which ultimately leads to better efficiency. Because we have little money, we need to focus on something which can really change the acquisition of disease rather than acquisition of prevention from disease, or managing a disease process that is already established due to inherent structure of the human being, that is malnutrition and other environmental factors. Poverty is one of them, food is another, education, lack of education is another. Money for money, these interventions, whether it's global analysis or people in the health sector or in the finance sector, IMF or World Bank, economists have underscored this point. Tackle these basic issues first and then tackle other issues later. If we need to only focus on cancer or cardiovascular illnesses, I have a feeling that we are not putting our money where public money should go. The fifth kind of paradox which I have always been facing the last 30 years is integrative versus discrete centric entities model of delivery of care. If you see the history of health sector reforms or health sector implementation all across in the center of the states, even in corporates, it has always been fashioned around certain disease or program specific projects which last for 5 years, and it is recrusted into another program after another 5 years, and the cycle goes on. The process of integration, which began in 2007 in India through the NRHM, will ultimately will reach its natural progression, so to say, with the National Health Mission in the next 5-year plan, if it is actually accepted on the ground. There's a lot of debate at the moment in terms of whether we should have two vertical national rural health versus national urban health missions, instead of having a unified national health mission. The country is divided into, artificially, into so-called urban and rural, while actually the country resides in the grey zone, that is between the rural and urban, because India as such is transforming. The real story of health sector reforms and actual execution and health status improvement will occur in tier 2 and tier 3 towns and cities. If you see the growth, economic growth, if you see the health status improvement in the last 30 years, it has actually happened in tier 2 and tier 3 cities. And in the so-called artificial divide, of urban versus rural. These tier 2 and tier 3 cities they can be ignored at the cost of so-called very rural or so-called tribal and unreachable versus very urban metros, which have population more than 20 lakhs, say 40 lakhs. And they are very aggressive. They have all the media is over there. Everything gets noticed. The ultimate sufferer is the tier 2, tier 3, where actually, as ISBY has shown, that health sector is functioning there. Because if you analyze the health institution in the country, surprisingly you will find a shocker. Most of the hospitals are individual doctor owned, not even a businessman owned. Leave aside more than 30 beds. International definition of a hospital is 30 beds. You can't call a hospital as a hospital if it does not have 30 beds. But most of the hospitals in our country are actually less than 30 beds. And they are labeled as hospital. Everybody perceives them as hospital, or somebody would call it nursing homes, somebody would call it some name, but they are actually perceived and advertised and utilized as hospitals. And they run on a very low occupancy rates. So both are the losers. The person who is running, who has invested his lifetime savings, his background, most of the individually owned nursing homes are from not publicly financed. They are financed from the pocket savings of that doctor, which is a worst way of investing public money for public purpose, or individual money for public purpose, for that matter. If this transformation is to actually progress and operational efficiency has to occur, this will not occur through so-called 5 major public limited companies in the health sector, namely Fortis, Manipal, Apollo, or Max, or other new chains which are coming. This will happen only through a process where these small, individually owned, existing tier 2, tier 3 cities located hospitals actually getting money for expansion, and a tool like RSBY for its occupancy to increase and actually transforming the whole world into a place where a person knows that my health is assured, and then he can start saving and investing for prevention of health, which is ultimately the real transformatory process. If the individual here is assured of health without investing his own money, or even if he invests, he is assured that there is insurance available through a public funding mechanism, that money saved, say 30,000 of RSBY, invested by an individual in terms of savings, in terms of education, in terms of livelihood, in terms of actual prevention, in terms of, say, better quality of food, more education in terms of better knowledge about prevention from disease. That is the real value, and that is the real GDP, which ultimately makes the progress from a developing to a developed society. The last paradigm which I want to put across is round table, and I don't want to be prescriptive, is the model of learning and doing versus teaching and getting done. These two paradigms, ultimate success lies in learning and doing. Having traveled all the so-called 6 continents of the world and the seas lying between them, I feel anybody who says I know need to learn a lot what he does not know. He does not realize what he does not know, because the world is changing every day. It is transforming. How can we say we know? We learn and we do from what we learn. It's foolish to talk that I am a teacher and I know what I'm teaching. I've become a teacher because I want to learn. I want to improve myself through the process of interacting with the students. That process, I think, is the model which is required to achieve operational efficiency in health management. You don't need to be a health expert, you just need to be a simple citizen of this country to make an effort in improving operational efficiency, as civil servants have shown. Last point I want to make, this forum for consideration of the roundtable members is actually when we travel all across the country, the lessons come through sheer power of observation. It does not come through textbook or research studies in social science or economics textbooks. It comes through actual interaction with the people in the rural hinterland. This I came to know very early. 1983, I was recruited by the National Institute of Health and Family Welfare for assessment of laparoscopic sterilization in the state of UP. And I just passed out 3 years just after my graduation. I was specialized in pediatrics and a pediatrician. And the task given was to travel to village, medical college, district headquarters, taluka headquarters and tehsil headquarters of 13 districts in UP over a period of 6 months. For a medical graduate who has studied and graduated from so-called one of the best medical colleges, to travel to these areas on a random basis. I could not predict which village will come and how far that will be. Over the next, say, 6.5 months, it was an eye-opener. To travel to reach out to a lady who was operated 2 years back in a medical college hospital, say Jhansi, and her address comes out through random selection in a village where I had the last jeep which the district magistrate was providing could reach, and then I have to take another vehicle or say a horse cart or whatever, but I had to walk 10 kilometers on 2 occasions also, because that lady was residing there. And this is 1983. And every record of the feedback, I had to actually see that the work, with the social scientists with me, are actually recording the reality about how that lady traveled to get herself operated. Mind you, it was laparoscopic sterilization way back in 83, and I had to assess the quality. Centric is one surgeon operating in a medical college, in a district hospital, mostly the teaching medical college hospital in UP. It's a lesson in its own right. If that lesson SAP wants to learn, it will not be learned sitting in Bangalore. It can never be learned in sitting in Bangalore. One needs to travel in the rural hinterland, right from metro to tier 1 to tier 2, tier 3 cities, and they are cities and towns in their own right. And ultimately travel to the person who is actually not having any resources of livelihood. Leave aside land or leave aside, I would say, even say food. If we have to reach there, then I think, and if we are able to reach there through ICT, then actually we have a tool for transforming India and ultimately achieving the so-called operational efficiency in healthcare management. Because that is real healthcare management. When we say health, it is not disease management. Health includes a bigger term. Take up any definition of health, whether it's WHO or Government of India or Planning Commission or any expert for that matter. I've taken a lot of time, but I think the points made were essential, and if I have tread on certain soft toes, pardon me for that. Thank you.
Thank you, sir, for highlighting some of the most important parameters that impact achievement of operational efficiency. May I now invite, and I hope I get your name right, sir, this time, Dr. Tirunavukarasu. So you'll have to teach us how to pronounce it. And he's a Deputy Director again from HMIS, Tamil Nadu Health Systems Project. And as we all know, Tamil Nadu is one of the states that has used ICT in a big way for not only healthcare but a lot of other sectors. So, sir, please tell us about what Tamil Nadu is doing.
Good evening, ladies and gentlemen. Greetings to you all from Project Director Thiru Pankaj Kumar Bansal, IAS. So, in this forum, I'd like to highlight only one point, which is the need of the hour. That in order to achieve the better operational efficiency in healthcare management in India, the actual need of the hour is to have one single platform for all IT-enabled health activities. Each state has got an HMIS and they differ with each other with various aspects. This forum can suggest the highest governing body for health in India to integrate all HMIS and have a unified one HMIS, and that is good for the country. And a central repository which is going to be a huge database, and that is the one area where SAP like organizations can have a major role. Let us all work towards that goal. Thank you. Thank you for the opportunity.
Thank you, sir, for keeping it short and sweet. May I now invite Dr. B.S. Bedi, Advisor Health Informatics from CDAC. He's also the President of Telemedicine Society of India. So, sir, please come and share your views.
Good evening, everybody. It's interesting, perhaps what can ICT do in healthcare. I think that is not debatable. The only thing is how we use it. That is the main issue. Already, you see, this is a very interesting thing. In America, about $27 billion are being pumped in on some kind of use of EMR, etc. And already there are skeptics who are debating whether it will raise productivity or efficiency in any major way in US. Anyway, that is beside the point. See, I will just like to confine myself to health delivery improvements, etc. through this modality of e-health or m-health or u-health or telemedicine. The question is, we have experimented enough. I think wonderful point made by Mr. Sarup, pilots, and we have a graveyard of pilots. But anyway, sometimes when you have too many pilots, that itself becomes a ground to test whether what and where they have led us, you see. I can tell you, from when this field started, we were at the forefront from two technology ministries, the field of telemedicine. One was, we started when even just before 2000, using all kinds of technology. Technology was a big challenge that time, I can tell you. The bandwidth was very costly, the hardware was costly, and the capacity building was expensive, people were not trained. And so we went in an integrated way that we'll look at all these angles, all kinds of bandwidths, different kind of hardware, and internet, ISDN, broadband, and whatnot. And then, there is a sister department, scientific department, very excited. You see. They also had a program, space for social sector. So certainly we found that two ministries, we ourselves from Ministry of IT, we are trying to develop technology, then apply it. You talk to the state health departments and collaborate with them and all that. And then more than 200-300 satellite-based district hospital connectivity was established by Department of Space. Gentlemen, how many of them are operational? This is a very big issue right now. In my own experiments, I find that some of the states, the experiment was very poor, and surprisingly, in some of the states, where perhaps the intervention was very effective. In Tirupura, it went out very well. Kerala, it was very effective. The question is, I think we have to very seriously look at what are the factors which made, some of the schemes in some states work. In Tamil Nadu also, the things were more or less operational. So perhaps it was the states which were enlightened, or So this is one particular problem. You see, now you see the e-health thing, etc., is coming in a very big way. Already, Ministry of Communication and IT through a national governance program, they have plans for bringing telehealth into 100,000 centers through their common service centers. And you see, all other services have started except for telehealth from those centers. There are some issues which are hindering its use. And now recently I was very excited to see that Ministry of Health through the Planning Commission steering group, they have, in the public health, they have really stated that, right from the sub-center level, we should go to the tertiary center and introduce telemedicine. So it is very important when we are looking at, from private sector, which is the national e-governance programs, common service center, which are basically village level entrepreneur and state level, they are service agencies who are driving it. And from the public sector, we are bringing the whole thing. Already a lot of experience is there, so we have to learn from the experience. Dr. Tarun Singh is there, through National Rural Health Scheme, and there also, we did a lot of things. And then the Ministry of Health had their own task force to look at those things. So this is one thing. The question is, sometimes these experiments are really exciting. I will just give one particular example. Our setting Onconet at Kerala has been a singular success. The programs which we supported there use all kinds of technology and realized that, and once we had withdrawn, but the scheme is still running. That gave Health Ministry enough incentive to roll it out. I mean, at least plan to roll it out to cover the whole country through 27 regional cancer centers. Because one state, it had functioned well. Gentlemen, Kerala, we have been looking at this program, but cancer, as you say, treatment is difficult. So the question was, can it be used for prevention? So when we did another very exciting experiment, and this has been very effectively on right now, we used a mobile or tele-oncology unit, which operates right now. See, this program is over. The whole thing has been handed over to an NGO who is managing it. In a very span, this is one well-equipped bus kind of structure, which not only had diagnostic, but also a bit of treatment system also, like cryosurgery unit. Only one, the most prevalent cancer, the cervical cancer was taken as one example, because if you prevent one, you can imagine the kind of trauma you can avoid. So basically for prevention of this thing. So the question is, again, the camps are held, the pre-announced dates, the van will go there, hundreds of people and thousands, the pre-screening is done, and the slightly vulnerable population checked, and then if there are any these things, the consultations are done through telehealth to the regional cancer center. Gentlemen, I can tell you, one well-equipped lab van is covering 3 states, and one span of just 1 year, 150,000 cases were scanned through, pre-screening and all that. And more than 110, 20 pre-cancerous cases were detected. So that means you have saved so many these things. So these are, I think, my submission is some of the such kind of programs. Just imagine now the same man is going to cover 5 districts. Imagine, a small investment can really prevent a major, preventable disease, which is otherwise once it manifests, it can cause a lot of, not only problems, expenditure, and also death. So my this thing is, let's study where some programs have been successful, where the efficiencies of healthcare efficiency through for delivery have improved through these technologies, and use those experiences. Although the pilots have come and gone, but they have left some experience. And why tele-ophthalmology programs are running so successfully? Why Arvind Eye Hospital is looking at more than 200,000 cases per year, and very successfully, and they are sustainable. Sustainability issues. Why the other national programs, when you are bringing in new policies, what can be the things which can make things sustainable? I was the evening when we were discussing. See, one major program, the hint you gave was that you had incentivized use of that thing. It's not only that a poor, common person is getting benefited, because the doctor is also getting something. So the scheme is doubly operational and successful. So this is, I think, gentlemen, I think we must look at some of these issues in our e-health program to make it much more efficient and usable. Thank you.
Thank you so much, sir. And may I invite Dr. Tarun Singh, and sir, please come and tell us from an outside the healthcare sector point of view now. Inside and outside.
Thank you, Divya. Thank you, Ravi, for inviting me. Thank you, SAP, for supporting this initiative. The country would always remember this contribution. And thank you for the earlier speakers. They have almost touched every relevant and important topic that is there to address in this subject. May I draw something from what Aniswarup sir had beautifully said? The video you showed was really impressive. But as a pickup line, it doesn't impress me. As a pickup line, you've got to address my pain point. If you, I belong to the IRS. In Income Tax Department, we have a saying that if you manufacture something for the masses, you will live in the classes. But if you design a product for the classes, you will remain in the masses. It's a little peculiar, and it's true in every sector, in education, in health, in any kind of public delivery. You design something, you throw a solution at my problem, it's unlikely it will work. It may appear to, but it won't. It won't stick, it won't be sustainable, and it won't be SAP, it won't be SAP. If it's SAP, you have to have the algorithm correct. And to have the algorithm correct, you have to identify and appreciate a very major deficiency which I have. I don't like computers. In health sector, I don't like ICT. The health department doesn't know where to locate telemedicine as a division. And division is a division in the ministry which handles files. It's the biggest playboy division, It jumps from one undersecretary to the other. Nobody wants it. Everybody wants it, but nobody wants it, and you will have a very tough time in many states, because the states have other bigger, more emergent, more immediate, more gruesome problems to handle. I don't just mean tsunamis and earthquakes. More gruesome could be an election. It could be many other schemes which are the current favorite of the bureaucracy or the politics or the powers that be. And therefore, please understand, we are now going to be operating, or you seem to be wanting to operate in a paradigm in which ICT has not been accepted or internalized in any substantive way. Point 2, is diagnosis a problem in India? Is prescription a problem in India? Is management a problem in India? All three of them are a problem. We don't even define stuff here. We don't define who is a doctor and what he is supposed to do. We also don't define what a nurse is and what she or he is supposed to do. And therefore, in our health system, operational inefficiencies often arise out of a mix of the team. And allow me to give an example of the pit stop in a race, in a Formula 1 race. When the car stops on the pit stop, everybody in the pit team knows what he's going to do or she's going to do. There's no leader there. There's nobody pointing out, tu udhar ja, tu udhar ja, tu udhar ja. But in health system, everybody seems to be advising everybody else ki aap udhar jaiye, aap udhar jaiye. We are not a pit stop team. We don't create pit stops team in the health system. And remember, health is no longer about the doctor treating somebody. It's a team that works. Very often the ward boy's role in the patient's experience in a healthcare scenario may be more important than the doctor's engagement, which may be only a very small percentage. Understand that a pit stop doesn't arise automatically. It is something that has to be defined. Every person's role has to be defined. Every person's standard operating guidelines have to be prescribed and therefore regulated. And he has to be trained to do that. And when you train doctors and nurses in the colleges. And therefore what we need is what the National Skill Development Council defines as occupational standards. Now occupational standards not being available is one of the big reasons our pit teams are not operationally efficient. Okay, and that's one of the big reasons we are unable to regulate them also. Because you don't know what role I am playing tonight. You know, I could be playing doctor, but I could also be playing nurse, or I could be playing ward boy for all you know. And therefore when you design your ICT solutions, who are you going to be designing them for? Which occupation or which definition, which hat I am wearing on a particular occasion. So definition is one big issue. You may have to import definitions into India. Many countries, the definitions are very well into space. The US systems have taken it to almost ridiculous extents of specificity. But there is something to learn from there, and maybe you could bring that down here. The second big point, you're on quicksand anyway, because technologies are changing every evening. So what RSBY has demonstrated to you is an enabling platform which can work. So don't you tell me that I need to prove that it works. It's well proven, but what technology will you bring in? You know, if you bring it today, it's a certain kind of bandwidth heavy, computer based, or maybe mobile based. Day after tomorrow it's going to be my eyelid based, and very soon it's going to be probably just, remember that Pranav Mistry video? Have people seen that? You know, things could be moving on my fingers. So the doctors would not be looking at their iPads. That's a rather inefficient way of spending a doctor's time. Now we won't be doing it in India anytime soon, but it's quite likely that as SAP, as a stakeholder in the business, to improve efficiency, you may be looking at products and technologies which are not there today. So let's not copy what we have done elsewhere and try to introduce here. Look for leapfrog possibilities. There are lots of them available. SAP has already used leapfrog technology in many occasions. Do the same here also. One of the important learnings that I had the good fortune of working for the National Rural Health Mission for some time. And remember, it wasn't about rural health delivery. It was not an architecture about of health delivery to rural areas. In the original cabinet note, the word used was health sector reform agenda. Okay, health sector reform agenda. Nobody said it's going to be for only rural areas and only primary health centers and sub-centers. The whole idea somehow strayed into rural health, because when we talk of inclusive growth, we often end up talking about poor people's growth. We don't talk about the middle income growth or the higher income people's growth. And therefore, and we don't talk about urban area or the tier 2, tier 3 city, which sir you very rightly pointed out. So what happened was that somehow the discourse took the shape of rural health mission, whereas it actually was intended to be a reform agenda. Now when you reform stuff, you do newer things. And when you do new things in government, what do you get? Audit objections. Okay, you get audit objections and you get all kind of mistakes, and all kind of people get up and all kind of press reports say that what you do is wrong, and therefore you take 2 steps back. So all reform agendas in public systems are going to be 3 steps forward, 2 steps backward, and SAP has to somehow design a system where it will be able to fit in the technology as we move ahead and as we move backward, because that's how we are going to move. That's how we are going to move in this democracy. The last point, what you've got to look for are disruptive solutions. Our EMR cannot look like a US EMR. Our scales are different. Our Aadhaar cannot look like a census or a social security number in a Western hemisphere country. We don't work like that. Our scales are different. Our possibilities are different. I don't think we are going to be able to include, or we even need to include, all data relating to a patient onto a given iPod to arrive at a health relevant decision. Maybe the relevance will give rise to the format rather than the format leading to some sort of a relevance. So whatever ICT tools or paradigms are being designed to improve operational efficiencies, disrupt what is being done, how it is being done. We don't need to do it in the way it is done in other countries. Maybe you've got to design something completely afresh, a priori, from ground zero up. It might be very useful because you may invent something for every 6th human being on the planet. And for all you know, we may be every 5th human being on the planet, because whatsoever has happened in the laparoscopic sterilizations in the country, we are growing very rapidly. And our skill, not only are our numbers rising, but our economic strength is rising. Now, as economic strength rises, the liability of the service sector to provide good health services and logical health services becomes all the more important. If we have a bunch of illiterate, unhealthy Indians in large numbers, the planet can kiss itself goodbye. So, to have India growing at the rate at which it is growing, it is extremely necessary for us to redefine dedicated modules for a country like India and not produce maybe carbon copies or photocopies of what we have done in the Western countries. NRHM, NUHM, National Health Systems Reform Mission, the nomenclatures can differ, but these are all government programs. The government programs by definition have to have a sellable product which can sell to the Planning Commission as well as to the Parliament and as well as to the common citizens and to the press. I don't think we should take it to heart that it missed out on the urban and the tier 2, tier 3 cities. The idea is that it set into motion a reform agenda where ICT has been demonstrated to have a very successful footprint and created possibilities for organizations and discussions like these and for people like Ravi to make a positive contribution to their event. Thank you very much.
Thank you so much, sir. As you very rightly said, healthcare is no more about just doctor treating the patient. I think it also is about use of ICT to enhance our services. With that, I would like to invite our last speaker for the day, Dr. Sunil Kumar. He is the Senior Technical Director at NIC, and NIC has been greatly involved in all government IT initiatives. So, sir, please tell us about what is happening on the NIC front.
Good evening. We have implemented e-hospital solutions in 20 hospitals across India. I would like to have only one point to make. Number of other solutions are there. When electronic medical record of a patient is to be transferred from one hospital to the other in case of emergency, it cannot be transferred. So I think we have to sit down before implementing those solutions in the hospital, so that if electronic medical record is to be transferred from one place, one hospital to the another in electronic form, it should be exported and it should be imported by two different systems. I think that is a point I want to make, and for that lot need to be done by us, by ministry, by health ministry, by technologists, because lot of standards have to be developed and a lot of homework has to be done. Either we have to adopt the standards or we have to make standard for that. We have already initiated and Ministry has also initiated a lot of effort in that direction. Thank you very much.
I think we have near the close of the session, and may I invite Shri Anil Swarupji for the closing remarks and summarizing the discussions and the way forward for us.
You got the wrong man to summarize actually. I felt enriched by what was spoken today. As I said, I look forward to these discussions to learn. And I may have some point of view, but such occasions are there to learn, and I'm so extremely thankful to the entire team of here for having invited me here. I think what we have to look forward to is understanding the processes in India. Because there is ICT. I mean, I have no doubt about the capability of ICT, but the question is the ground reality as it exists. And that is non-technical in nature, and hence there should be a partnership between those are there in the ground and those that are technologists. And if you don't understand the ground reality, probably we'll be going in the wrong direction. So first, I think, take from this discussion is understanding ground realities as they stand. The second point was so well made by the last speaker here. You know, I'm so glad it didn't come up before that. You know, we should not create these islands, these oases, which are not connected. You don't talk to each other. And I must give you an example here. We've done a little bit in RSBY, but I didn't expect the biggest health insurance company in the US to send a 5-member delegation to understand what we were doing in India. I was quite aghast. So they asked me, I told them, yes, we are learning, we are doing small things. No, but you tell me, how did you manage to create a national platform where your card works anywhere in the country? The data can be transferred from this hospital to that hospital to this insurance to that. How do you do that? Because they are struggling with it. In the US, every state has its own technology frame and they can't talk to each other. And you made a very pertinent point when you said data from one hospital cannot go there. So this takes me to the third point, and very aptly made, that if we don't evolve standard operating procedures, if we don't evolve standard guidelines countrywide, technology will be disastrous. And one reason why RSBY seems to be happening is that if you go to our website, almost every procedure is defined. Roles of every actor and player is defined. We are learning, we are changing it as we are learning. But as of now, if you go, what the district manager has to do, what the field officer has to do, what the enrollment team has to do, what the hospital has to do, there is a hospital manual, there is a FQ manual, there is a DKM manual. If you organize a workshop, there is a manual for that as well. Everything is defined. Until unless you do that for a scenario, we will run into serious problems. So the point number 3 that I take from here is, we must work very hard, as you rightly put it, for creating these standard operating procedures. Technology comes thereafter. What technology, you know, how people ask me, if you talk about these processes, procedures, where is technology coming? I said, technology has forced me to think logically. Because if I am not logical, technology will not accept. Because computer doesn't understand illogical things. They understand only logics. I don't understand computer at all, but I know this much, that if I am not logical, if I am not precise, if I am not to the point, if I don't define, technology doesn't help. So you will find individual solutions in individual places, and what my friend said, one will not be talking to the other. So this is the third take that I take from this workshop here, this roundtable workshop, that we have to focus on defining the roles, and thereafter the point number 4 comes is, set up a regulatory mechanism so as to ensure that those regulations, those definitions, those roles are performed by those that have to perform. The problem in this country is everyone wants to do everything. So no one does anything. It's like public property is everybody's property, is nobody's. So when you throw a stone at the bus, you feel it's somebody else's property. As if Angrezi abhi raj kar rahe hain, unki bus tod raha hu. You know, it's funny. We are hitting ourselves, we don't even realize we hit the stone. Why? Because I don't understand my role. And I don't blame them, because we don't understand our roles. Those people sitting here. So you keep treading onto somebody else's foot. Why should you? If roles are so very clearly defined. I would request you, because I look forward to feedback from you, because I want people to criticize RSPY. I want them to look at it with a microscope, see what is going wrong in this country, love it, because that's the only way to improve it. So please, my request to you is, please go to our website, rspy.gov.in, and please tell us where are those guidelines going wrong, where are the procedures, because we revel in it. We believe that keep defining, keep defining, keep refining, keep defining. And once you do that, ICT comes in. And it really helps us. Today, when I tell people that during the course of the day, if I don't travel once a week or twice a week to one state or the other, I don't have anything to do here. People don't believe it. You're running this new scheme. I said, during the day, there are a couple of hours, I don't know what to do. So I write papers. And a bureaucrat writing a paper now on this scheme, because I don't have anything else to do. And this happened because we slogged very hard to create those procedures. Now the only job we have is to keep improving upon them. And I do another funny thing, I don't do anything which other chap can do better than me. And I believe most of the people can do better than me, so I don't do anything. So I delegate everything, they do that. I give them an environment, the technologist is happy, my people are happy, everyone is happy, and it works good on. Thank you very much.
I think it was a great summary and key takeaway. I think what Dr. Suraj Kumar has said, if one hospital can transmit his data to another hospital without any errors, you would have actually defined a standard of the transfer of data, standard of EMR, and from a local EMR you can take it to state EMR and to national EMR. And as we heard about an amazing example, great inputs from all of you. Thank you all, and we invite you for a dinner in the adjoining room, and we will carry our discussions there. Thank you so much.